So today we will discuss the topic of ASOM, acute seborrheic otitis media. So it is acute inflammation of the middle ear, and the causative agents are pneumococcus H. influenzae, Moraxella catarrhalis, Streptococcus pyogenes, and Staphylococcus aureus, and Pseudomonas aeruginosa. Now, what are the predisposing factors? Now, recurrent attacks of common cold, upper respiratory tract infections, exanthematous fever like measles, whooping cough, that is pertussis, diphtheria, and there are other causes like other factors like tonsil and adenoid infections, chronic rhinosinusitis, nasal allergy, tumors of the nasopharynx, and cleft palate. Now, what are the routes of infection? Now, routes of infection are Eustachian tube, external ear, and bloodborne. Now, the Eustachian tube is narrow and wider. Sorry, it's shorter and wider in children, so it becomes easy for the organism to travel through the Eustachian tube. So, most commonly it occurs in children and infants, and through external ear it can go into the tympanic cavity by with the help of a tympanic membrane perforation. Perforation facilitates the entry of organisms, and bloodborne is actually least common. Now, what is the pathogenesis? Edema and hyperemia of the nasopharyngeal end of the Eustachian tube. We know there are two ends of the Eustachian tube. So the nasopharyngeal end, due to edema and hyperemia, there is blockage of the tube and air absorption. Now, due to this, there is a negative pressure inside the tympanic cavity. There is negative intratympanic pressure, as a result of which there is retraction of the tympanic membrane. Now, if it persists, if the tubal blockage persists, that is the edema, hyperemia, all this persist, then pyogenic organisms can reach the tympanic cavity, causing hyperemia of the lining of the tympanic cavity. Now, as a result of this, there are inflammatory exudates in the middle ear. Pus formation occurs in the tube, and there is bulging of the tympanic membrane. Now, the tympanic membrane may rupture and the pus is released into the external auditory canal, and this may lead to further complications. It may also cause it may also spread to the other parts. It can cause labyrinthitis, mastoiditis, and whatnot. What are the clinical features? The clinical features are mainly, you should notice is that deafness, earache, and cartwheel appearance of tympanic membrane. These three are most important. So deafness is usually it is of conductive type of deafness, and as it is a acute inflammation, as it is a acute condition, so the earache is excruciating sometimes, and also after the perforation occurs, there is air discharge, and before the tympanic membrane ruptures, you can appreciate cartwheel appearance on the tympanic membrane. And as it is an inflammatory condition, so fever may be there. What is the treatment? Now, at first you have to administer an antibiotic. So the antibiotics are ampicillin and amoxicillin. Ampicillin, the dose of the ampicillin is 50 mg per kg per day into 4 divided doses, and amoxicillin 40 mg per kg per day in 3 divided doses. And apart from that, you can also use cefaclor, trimoxazole, erythromycin, amoxicillin, clavulanate, augmentin, cefuroxime, cefixime. All this you can administer, but the most effective treatment is amoxicillin and ampicillin. Now, ampicillin is not commonly used now. Amoxicillin is preferred, so you can use that for 10 days. Now, there are some decongestants: ephedrine nasal drops, 1% in adults and 0.5% in children, and oxymetazoline and xylometazoline. These are nasal decongestants. There is another one, pseudoephedrine, 30 mg twice daily, with or without antihistaminics you can administer, and paracetamol for fever, as you know. And to get rid of the ear discharge, ear toileting can be done. And also we can do dry local heating. We can apply dry local heat to the ear for pain relief. And myringotomy can be done before the perforation occurs. So this is all about ASOM.